quick things and then turn it over to Jack, our chair. First, and we'll talk a little bit more about this at the end. Today we'll talk a little bit more about public meetings law, but just as a opening remark, just a reminder that this is a public body subject to public open meetings laws and public records law. We'll talk a little later about what that means, but we're being live streamed as well, and we'll have that recorded. I should let everybody know, I think everybody knows me, that I'm Jeremy Vanny. I'm the Director of Health Policy Analytics for OHA. Just real quick, let me cover the agenda, just a really high level. We're gonna spend really today doing some level setting and really setting the groundwork for the work that's ahead for the next year. So we'll spend some time on welcome and introductions. We'll spend some time on a little bit of background on why we got here. Some of this might be repetitive, but we just want to make sure that we got an opportunity to sort of baseline with everybody and we're all starting from the same spot. We'll talk a little bit about how this works in other states and kind of what a cost growth target is. That will be the first sort of part of the morning. The second part of the morning, we'll talk about the charge of this group and the charter and talk about operating procedures and how we'll all work together, as well as kind of map out what the next several meetings look like. As I mentioned, we'll talk a little bit more about just what it means to be a public body, public meetings law, have some time for public comment at the end, and then we'll be wrapped up around noon. So I'm going to turn it over now to Jack Friedman and Dr. Kevin Iwanchina, who are our chair and vice chair, and let them kind of kick us off with introductions.
Great. Well, thank you very much, Jeremy. It's lovely to be here, and welcome to everybody. I'm glad to get to know everyone over the next year. We're going to spend a lot of time here together, which is good. I wanted to make just a couple opening comments and see if Kevin does, and then we'll do some introductions, and we have some guests, too. I know that we want to, and I have someone on spam calling me. You know, first of all, it's a real honor, right, to be part of this effort. I think all of us would say that there's no better time to try to figure out a way to put up a cap on healthcare spending, which is probably more than 20% of our GDP in this state. And I was discouraged to see in the slide deck that our citizens face the fourth highest burden of out-of-pocket spending for all of our citizens. So we have to do better, and we can do better. I would like to think that we will all participate fully and be honest and forthright. I'm going to do my very best to make sure everybody has a chance to speak and to get your points of view across. And so if I don't, please hold me to it. But I love a meeting where I get to run it, to be honest. So, that's how I spend most of my life at Providence. So I will do my very best to make sure everybody has a voice here. I would also say that while most of us here represent some organization or some sector of the industry, whether it's on the payer side or provider or consumer, whatever, let's remember why we were appointed, which is to watch out for the interests of the citizens of this state who are facing increasingly a tough way to spend their health care, even when they are covered. So we are here to represent our citizens and to try and create a system in which people can increasingly afford to use healthcare, and also to try to make room, right, for other social investments in our state, whether it's education or housing or, frankly, better roads driving over here. We have a lot to accomplish, and this gives us a chance to free up some dollars that are sorely needed to invest in other parts of our social good. And then finally, I would just say, let's try to learn from what we've done well here. And let's not make the perfect get in the way of the good. And so my goal is going to be to try to move this process along and try to keep it simple and not try to be perfect in everything we do if it gets in the way of us accomplishing something meaningful. So with that, I'm going to say thank you for your time and your efforts here. It's a commitment, and we deeply appreciate it. And I know that most of you have day jobs. I'm not one of those anymore. So with that, I'm going to turn it over to Kevin and say, Kevin, you want to make a comment? Then we'll do some introductions, and I know we have some comments from Tina. And I also know our governor is here. John Kitzhofer is here. And John, I'm going to ask you to make a comment or two when the time is right here.
Thank you so much, Jack, for the introduction. And for those of you that don't know me, my name is Dr. Kevin Ewinchin. I'm a family physician based in Corvallis, and I'm part of Samaritan Health Services. I serve as Chief Medical Officer of the Health Plan Division of Samaritan Health Services and Chief Medical Officer of Intercommunity Health Network, one of the coordinated care organizations in our state. I'm also a transplant from Canada, and I practiced there for many years, so I have a unique perspective in the delivery of primary care. But I've been a practicing physician in the state of Oregon for 21 years and really pleased to be in our state. I'm also really excited and pleased to be part of this innovative and constructively, proactively working group where we can constructively look at healthcare costs and create a total cost of care benchmark without finger pointing. I think that's really, really important as we go through this journey, that we all have a part to play in the cost containment of healthcare. I've seen the growth in the state of Oregon over its innovative approach to healthcare and been very pleased to be practicing within that innovative approach. I've been in the delivery care system under our state's Medicaid program, the uniqueness of the Oregon Health Plan, and the rational rationing of the prioritized list that was developed by Governor Kitzhaber. I've also seen firsthand the increasing burden, though, put on my patients due to medical debt. Whether it is the cost of medical services themselves, their cost sharing, or the increasing cost of prescriptions, or the increasing cost of insurance deductibles and premiums. Many patients and families are seeing these costs as unsustainable and prioritize food and housing over some of their medical care. It is a perception also that physicians do not want to be part of this change that is necessary to undertake, or that we don't care about the cost of care. An October 7th, 2019 article in the Journal of the American Medical Association acknowledges that the total annual cost of waste in the healthcare setting in the United States equals above $1 trillion. And a Health Affairs article highlighted that about 1 in 5, only 20% of orthopedic surgeons in the country could correctly estimate the cost of a common orthopedic device. But over 80% of those same orthopedic surgeons consider cost as a key criteria in the selection of that medical device. So physicians and surgeons do care about the increasing cost of care, and we want to be part of that solution. We just need to understand the healthcare cost accounting system. We also in our state have a lot of opportunities to leverage the social determinants of health due to these components being the largest contributor towards an overall individual's health outcome. So I feel that that will be really important for us as a task force to understand the role of the social determinants of health in the overall total cost of care. We cannot fuse those two apart, and it's important to keep looking at those as a component of the total cost of care in the state of Oregon and nationally. So thank you for the opportunity to serve as your vice chair, and I'm looking forward to what we can create collectively.
Thank you, Kevin. Did you want to do a housekeeping?
Yeah, a couple
before we go around that.
A couple of housekeeping things I should have mentioned earlier. So first of all, we have too few mics for folks, so a couple folks might have to share. These power buttons do work, so make sure that it's on green, and if you don't want to be heard, that it's not on green. Restrooms are just out to the door, straight back. We've got snacks, feel free to help yourself. So I think that covers the bases. And then Felicia Higgins is on the phone as well.
Oh, great. So why don't we do some quick introductions, and just give us your name and background, and we'll get started. I know Tina has a couple of comments to make, so maybe we'll start with you, Jen, since you came the furthest, I think. I'm not sure.
I'm Jen Nealon. I'm the Chief Financial Officer for St. Charles Health System over in Central Oregon. And I've been with the health system about 10 years, native Oregonian from Philomath, Corvallis area. And I was also on the task force that led to this, the 419 task force. So happy to be here.
Angela.
You should turn your mic on.
Oh, yes.
There we go. Angela Dowling, President of Regents Blue Cross Blue Shield. I've been here about 7 years, have worked in multiple states around the country in the industry, probably longer than I'd like to admit, a little over 30 years, and thrilled to be here, thrilled to participate in the committee. Jenny Smith,
CFO, Kaiser Permanente, working at Kaiser for 20 years from coast to coast. Covers the medical group of practice, health plan insurance, care delivery operation, hospital operation. So now I'm in the Northwest region. Pleased to be here.
Jenny, I'm sure your company is going through a lot of grief right now, and we just want to acknowledge the passing of Bernard Tyson. He was a giant in this industry, and we are sorry with what you're going through.
Thank you.
It was a
We
huge
really
loss to
appreciate
our
the
country.
pulling in the support from everywhere.
Yeah, good.
Jordan Pape, the CEO of the Pape Group. We're a private family business headquartered here in Oregon, out of Eugene. We specialize in heavy equipment dealerships up and down the West Coast, so we have familiarity primarily with Washington, Oregon, and California. And I have served as a director on a CCO and also on the governor's Medicaid budget task force in the last session.
My name is Catherine Correa. I'm one of the newest folks here, maybe somebody has since come. I've been in Oregon about a year and a half. I come from Minneapolis most recently, spent about 30 years in integrated delivery system and provider-owned health plans.
Good morning, everyone. Andrew Stolfi. I'm the Insurance Commissioner for the state of Oregon, but also representing the Department of Consumer and Business Services. I've been in this role about the same amount of time. Having previously served as a regulator in one other state.
William Olson, I'm the Chief Operating Officer for Providence Health System in Oregon. I've been with Providence for a long time, over 30 years. I was the former Chief Financial Officer, and recently, within the last year, moved into the Chief Operating Officer role. And I also served on the 419.
Great. Good to see you, William.
Yeah.
Hi, I'm John Connell. I'm the Director of the Center for Health Systems Effectiveness at OHSU. I'm here not representing OHSU, but doing my best to provide a health economics lens and bring views and evidence from the field.
Hi, Megan Burns from Baylor Health. Michael and I are here to support the committee. The organization has been in existence for over 20 years. We're a state healthcare policy consultant firm.
Hi, I'm Tina Edlund. I'm Governor Brown's Senior Healthcare Advisor. I've been involved in health system transformation in the state since I was about 12, I feel like, but for a long, long time. I also I'll have a few comments after introductions, but I want to offer the governor's apology. She's on a trade mission in Asia. Really wanted to be here today, but couldn't get back from Asia in time.
We'll be back to you in a minute.
My name is Michael Baylett. I am both pleased to be Megan's colleague and also to have been working in Oregon since Tina engaged me in the beginning days of the CCO program.
Good morning, everyone. I'm Ruby Houghton-Pitts with AARP Oregon. I have my roots in Oregon from the University of Oregon to CARE Oregon. Stepped away from the state for about 14 years, have been back for a year, and came back to assume the position as the state director for AARP Oregon. For those of you with gray hair, or who may be hiding gray hair, don't do it. I welcome you to join AARP Oregon. We are the premier organization for people 50 plus and their families.
Great, welcome.
Good morning. I'm Mark McCollum, the Oregon State Economist. I was appointed to my role about 9 years ago now, and I'm just here to help with the numbers.
So you've already heard from me, Kevin Ewan-Chen. I'm a family physician, been practicing here in the state for 20 years. I'm a transplant from Canada and practiced in that system as well. I'm very proud to be the vice chair of this task force, and I'm really looking forward to what we can accomplish together. I also serve as the current president of the Oregon Medical Association.
Well, Canada might serve as a model for us. And by way of background, my name is Jack Friedman. I served for many years as the CEO of Providence Health Plan, retired about 4 years ago, and have been serving on a number of boards, including Legacy's board and a number of others, and I'm just thrilled to be here, so thank you again. Now, with that.
Couple.
Oh, a couple more pieces. Excuse me. Yes, please, sorry. You go ahead.
Again, Jeremy Vandy, I'm the Director of Health Policy Analytics for OHA.
I'm Pat Allen, I'm the Director of the Oregon Health Authority. I've been here for about 2 years. Before that, I was the Director of the Department of Consumer Business Services for about 6 years.
And I'm Ken Preventure, I'm CEO of Pacific Source, where I've been for 25 years, CEO since about 2000, 2001. We're a health plan across Oregon, Idaho, Montana, and Washington, play in the CCO space, Medicare Advantage, and commercial.
Great. And we have somebody on the phone who'd like to introduce themselves.
Hi, yeah, good morning.
Sorry.
Well, I'll go first. This is Craig Anderson. I'm Senior Vice President and Chief Actuary with Moda Health. As others, I previously served on the 419 task force, and I'm in round, and I will be joining you shortly.
Felisa?
And Felisa, yeah.
Hi, I'm Felisa Higgins. I'm the Local Director at SCIU Local 49. I previously served on the Oregon Health Policy Board.
Okay. Is that everybody? Is there anybody else that we've missed on the commission? Okay, well, thank you all very much. Tina, you wanted to say a few words? And
Yeah. Before you jump in, just introduce a couple of staff.
Oh, yeah,
real quick
please,
first,
please,
sorry.
yes, yes.
Just so folks know who all you're working with. So this is Jen, and you've gotten appointments from her. She's our administrative support for the committee. And I should also say, if you have scheduling folks that you want in the loop, because I personally screw up my schedule, please let Jen know. She would love to be able to work with them directly. Zachary Goldman is our lead policy advisor for the interim. I'm excited to share that we've actually just hired another policy advisor that will be on to really support this committee all the way through. Sarah Bartleman will be starting in early December. She, for folks who know her, she basically was the lead policy staff that stood up the CCO Quality Incentive Program. So really excited to have her on board. She saw a new challenge and has wanted to dive in and tackle it. So just wanted to make sure folks know we're basically your team that will be supporting you, and feel free to reach out to any of us.
Tina.
Thank you.
Yeah, thank you.
Okay, so I thought I would just have a few comments from the governor to help kick off the group today. As we all know, with all the efforts that we've had in Oregon, Oregon has been a leader in healthcare reform. We still haven't achieved a sustainable rate of cost growth in healthcare. We know when we look at the numbers, it doesn't appear that it's utilization. It actually appears that it's prices. I think it's been said before that the price is stupid, but we really haven't had a chance to grapple with that. Healthcare costs are growing at a pace that outstrip the cost of personal income, outstrip the growth in the state budget, outstrip the growth in state revenues. We can't, over the long run, afford that kind of cost to businesses or to citizens in the state. It also continues to eat up an increasing amount of the GDP of the state or the country. It accounts for about 19, I think you said 20%, 20% of the GDP. It's projected to get much, much higher than that, and if we don't get our arms around it and tackle that issue. We've had incredible success in the public sector with the Medicaid work that we've done over the last several years with health system transformation, capping growth there, the per capita growth at 3.4%. We've achieved that every year of the waiver of the work that we've done in the state in Medicaid and in the Public Employees Benefit Board, as well as the Oregon Educators Benefit Board. It's becoming increasingly difficult to do that. We look at underlying cost growth that's pushing up around, I think, 7%, up against that goal of 3.4%. So we really, again, we need to address that very specifically. For the first time ever, and we've had the other big success, I think, for Oregon is for the first time ever, the state funded, through some of the work that Jordan participated in, we funded the Medicaid program for 6 full years, so that takes some of that off the table for the every 2-year discussion about how we're going to fund Medicaid in the state. We have a package that funds it for 6 years. Again, we will outstrip the goals of that package if costs continue to grow at the rate that they have. So this group is really to talk about how we spread that cost growth effort to the private market. What might we do to establish a target that that is akin to the 3.4% that was established in Medicaid. I'm not saying it's the 3.4%. That was the number that we established for the sake of the Medicaid program, but some number that's attached to some economic indicator that we can actually look to for a target for cost growth in the state. So the governor has some very specific things, specific direction for this group. When she selected the group, you're all your senior members in your field or in your businesses. She wanted to make sure that it was senior level people at this table, so that we're getting people who can actually commit to the effort. I think it's really important to ask that everybody try to take off their industry hats during this effort and really try to think about this as a collaborative effort. So what her direction is, or her guidance would be, that we really look for an aggressive target, an aggressive restraint to cost growth. If we do something that's close to medical inflation, obviously we're in that same problem of being not unsustainable. We want to make sure that we're transparent in this work around what the cost drivers are in healthcare. I think it's really important when we're looking at the total cost of care to really dig down and look at what those cost drivers are. I don't want to forget quality. I mean, it's always the challenge, right? That when we start to talk about reducing costs, that we do that by sacrificing quality, and we're not. That is not the aim of this group at all. We want to keep quality and equity right at the front and center of this work. And then the last piece is that I think this group is going to need to address the issues of accountability and enforcement once this target is established by this group. We're going to need to think about how accountability around that target is held. So on behalf of the governor, I want to thank everybody for coming here today and for agreeing to participate in this work. I think it's some of the most important work that we're doing in the state right now around healthcare. I will tell you a story about Jeremy presented this idea at a national meeting a couple of months ago now, right? And the response in the audience, the response to people from Congress who were in the audience was that this was, we're one of a handful of states. It's like 2 or 3 states now doing this work, and they feel like this is the path to the future, and it's very important work. Thank you so much.
Thank you, Tina, very much. Since we heard from the current governor, I thought that John Kitzhofer is here, our previous governor, who was kind of the architect of our CCO work. John, do you want to just take a moment and give us a quick word of inspiration? We could use it.
I wanted to say this for a long time. Chairman Friedman. For the record, John Kitzhofer, former governor. I didn't obviously bring any prepared remarks. I wanted to make maybe just a couple of points. First of all, I just can't emphasize how important this work is. I want to commend Jeremy and Pat for leading the charge. The growing cost of healthcare ultimately trickles down to the people that we all serve, whether we're elected officials or whether we're providers, whether it's a high deductible plan or just not having coverage. But the cost eventually comes down to people who simply can't afford it. I think that we have had 7 years of experience with a target rate, the 3.4% that Tina mentioned. So I hope that, I don't think we have to reinvent the wheel. I think we have probably a base that's ahead of most other states in terms of trying to move that target. But the target does have to apply across all payers, or you can't solve the problem just with the Medicaid system alone. So I think that for the providers, for the healthcare stakeholders here, I think this is one of your best opportunities to shape the future as opposed to having the future run over you. And as an example, I would point to the Policy Administration in Colorado that has proposed a public option that's designed to reduce rates in the individual market by 9 to 18%, solely by capping Medicare rates at $175 to $225 for hospitals only. So if you think about that, it doesn't address pharmacy, medical devices, doctors, or anything else, right? And those costs will simply be shifted to the commercial market. So we have to have some kind of a holistic approach. I'll just conclude by saying that I'm sure you've seen that scattergram that came out of the Network for Regional Healthcare Improvement that compares the 6 regional markets, showing Oregon has very low utilization and probably the highest rates. And if you look at the scattergram, which are clinics, that primary care clinics that have at least 600 commercially insured lives. If you were to move all the clinics to the 25% of the average of the top, right, it's $2 billion a year across all payers. So there's lots and lots of money here that would be better used in education or housing or raising up what we pay our healthcare workforce. So thank you for doing this, and I really appreciate it and wish you luck.
Thank you very much, Jim. Thank you for being here. Okay, I asked Jeremy to kind of get us started. I thought it would be very helpful for our commission to hear directly from him. I consider Jeremy our customer here. And so I'd like you to take a few minutes and tell us specifically from your perspective and for the OHA, what does success actually look like to you before we get started? So we know what we're aiming for.
So I appropriately delegated up to Pat.
Okay. Okay, great. Pat out. Good.
So we'll tag team this a little bit, actually,
All right.
both of us. And I think from OHA's standpoint, success really looks like three things. I think we start with an improved sense of transparency around costs in the healthcare system. For most people, it's a black box, and it's a black box in a couple of respects. Will Rogers once said something to the general effect of, "It's not what people don't know that's the problem; it's what they do know that just ain't true." And I think we've got kind of both problems of just not knowing and knowing a bunch of things that aren't true. And so trying to really break open that black box and get a better understanding of what drives healthcare costs and what are they and where are they, where do they shift, where do they move, where are they being contained and where are they not, I think is really important. Alignment, improved alignment across the system, I think is really important. We've done, as Governor Kitzhaber mentioned, a long period of work now focusing on coordinated care organizations, and in the last 2 years we've begun to migrate that into the other healthcare that OHA purchases through the Public Employee Benefits Board and the Oregon Educator Benefits Board, with the 3.4% cap now applying to those bodies, as well as an alignment around value-based payment structures, which I think is really helpful. But still, as significant as that is, it's only about 1 in 3 lives across the state, and it leaves plenty of opportunity for costs to move around or be perceived to move around. Back to the what do we know that maybe isn't true or don't know. And so being able to align across systems, I think, is really crucial. And then finally, that's all aimed at really trying to manage costs at a sustainable and affordable level. We've sort of gotten used to the shorthand of the 3.4% sustainable growth rate phrase across the Oregon Health Plan, and as you'll hear probably over and over and over again, 3.4% is not a sustainable growth rate as long as the economy tends to grow at about 2%. And so, trying to figure out how do we start to shrink that and really get to a place where we aren't devoting ever more of our income to healthcare is really the ultimate goal. With that, I'll go ahead and turn it over to Jeremy to fill in a few.
Thank you, Pat.
Yeah, I'll just add a few details. I think on the cost piece, I mean, fairly obvious. I think that's the reason we're here, is ultimately we need to get to a lower growth rate of healthcare costs. And I think ultimately folks will be looking to see whether this is successful in terms of that key measurement of what's the state able to lower the cost to something lower than what it's expected to grow at. I think there's a couple of subcomponents of that are important though. First, I think it starts with a commitment. I mean, on the CCO side and Medicaid, it was in large part because we had a waiver pending, but it did start with health systems, CCOs and providers saying, this is a bit scary, but we've got to collectively do it, and we've got to sort of hold hands and sort of jump off together and figure out a way to make it work. And so I think folks will be looking for that commitment, and that will be kind of the first indication of success is this group picking a target that is an aggressive target and making that commitment. I think in terms of overall total cost being reduced, we are talking about total spending, so both premiums and claims covered by insurers, but also out-of-pocket costs. I think that latter is becoming increasingly more important, especially just even the last year since we started this work. I don't think this is going to be seen as successful if we lower the rate of growth to 1 or 2 or 3%, but out-of-pocket costs keep growing at 5 or 6%. And I think that's something that we're going to have to grapple with, but ultimately, I think the legislature is going to see this, not going to see this as a success if they're still getting constituent calls that their deductibles and out-of-pocket costs are growing at an unsustainable rate. I think on the transparency and accountability piece, I I've had the opportunity to go back to Massachusetts twice and spend quite a bit of time with them and talk with Delaware and Rhode Island. And so I've been just formulating some thoughts based off those conversations. I think, as Pat said, on the transparency piece, we have a completely fragmented system, which makes it very difficult to figure out where the truth is. And I think getting to a spot where we've got a common framework of understanding what's driving healthcare costs, where's the sort of the truth, and us all being on the same page in terms of understanding what those key cost drivers are. I think success at the end of the day is a common framework where we can measure and understand costs and cost drivers in a way that stakeholders, as payers, as providers, we understand that, but also the public, the media, and policymakers all can have a common understanding of what's driving healthcare costs, and that's all transparent and is out there through an annual cost trends hearing, an annual report, and ultimately I think that transparency will lead to accountability. As Tina mentioned, there's got to be some sticks in here as well, but I think transparency and ultimately meeting the target and folks understanding what's driving healthcare costs would be a huge success in and of itself. Finally, the other piece that I've been really thinking a lot about is alignment and collaboration. As Scott mentioned, I think there's two buckets here. First is, I think, the alignment across payers and providers and the state around the things we can be doing to impact total cost of care. So we know that 25% of healthcare spending does nothing to improve health. Largely it's seen as waste and inefficiency and low value care. There's opportunities for us all to work together to figure out how we tackle that and squeeze that low value care and waste and inefficiency out of the system. And so I think that's the type of alignment and collaboration that if we all make a commitment to a lower rate of growth, that we then figure out how we work together to try to improve that efficiency. It was at Zeke Emanuel's presentation last night. He spent a lot of time talking about folks with chronic conditions and the fact that that's where most of our healthcare spending is going. And so this shouldn't be about reducing people's access unnecessarily. It really should be about how do we improve the care people receive in a way that improves their outcomes, and particularly for those with chronic conditions. And I think that if we do this right, we'll end up collaborating more and trying to align best evidence and emerging practices and figure out how to spread those in a way that ultimately improves outcomes and lowers costs. And then I think ultimately we've got to change how we pay for healthcare and figure out how we better align our efforts toward value-based payment and fundamentally move from a system that is incenting more and more services to one that is paying for value and outcomes, and specifically one where there is a financial incentive for insurers and providers to share in savings when they reduce costs. And I think there's a huge opportunity by first committing to a growth target to then figure out how do we align across payers and really move forward on value-based payment in a way that doesn't drive providers crazy, that actually helps them get there as well. The final piece of component of alignment and success, I think, is on the policy side. So my big takeaway a couple weeks ago, I had the chance to visit the Massachusetts cost trends hearing, and my big takeaway was how much they have aligned the executive and legislative branch through that process along with stakeholders. So they're 7 years in, and they reminded me it's taken them some time to get there, but they had the governor, the attorney general, the speaker, the House, the Senate president, all engaged over a 2-day period, broad groups of stakeholders. And not to say that everybody agreed on exactly what the problems and solutions were, but they're moving towards using this program to create some alignment across the executive and legislative branches, and alignment across stakeholders on understanding where the challenge is and where should the policy focus be to get the best bang for the buck. And so I think if we do this right, we start to move in that direction and figure out how do we give the legislature, frankly, it's the information and tools that it needs to be able to figure out of the 500 or 700 bills that come before it related to healthcare, which are the ones that are really going to help us move the needle on costs. So this would be some additional thoughts.
Very helpful. Thank you. Any comments or questions for Pat or Jeremy? Okay. All right. Well, that's a good start. And hey, so far we're right on time. This is excellent. So you're going to take us through some of the handouts that we saw before and present some of the background for us, yes?
Yeah, so I'll kick us off here with a little bit of background. Just so you know what's in your packet, if you haven't had a to breeze through. So obviously you got the agenda for today, the charter for this group, or proposed charter, which we'll spend some time later in the morning going through. The full slide deck from today is in here, and at the very back, just so you know, we've got all of the meetings scheduled up through May. We're still trying to finalize June, July, and August, and I think we're pretty close to that. But no, folks are anxious to get time on your calendars. So those are all in the very back, and we also charted out the expected topics, just so you got sort of a roadmap. We'll adjust as needed, but we just wanted folks to kind of see how we're expecting this work to sort of progress throughout the year, so you just have kind of a quick visual on that.
Yep.
So what's the problem? And I apologize, I know many folks have seen me do variations of this before, and they're probably getting a little tired of seeing it, so I'm sorry, but we decided one last time, just to make sure everybody's kind of grounded. Healthcare costs are really high. In Oregon, a recent estimate is that the equivalent to income of family premiums, or to put it another way, family premiums for folks who get healthcare coverage through employer-sponsored coverage, which is about half of the state. Those premiums now equal 29% of household income. So thinking about that a little different way, healthcare is making up almost a quarter of folks' compensation if you add income and healthcare together.
You're talking about total premium,
Total premium,
not the employee share.
That's right. Total.
At least not yet.
That's true. That's right. Yeah. Yeah. So what the employer is contributing as well as the employees.
Okay. Just to be clear.
Oregon has deductibles have been growing nationally for the last several years. Not good news for Oregon. We are the third highest in the state, at least by one estimate, and deductibles are just under, on average, $4,000. And obviously, this ranges pretty broadly beyond that.
Can I ask you a question? I'm sorry. That's deductibles. Do we know anything about other out-of-pocket spending? Is that everything, including deductibles and co-insurance, or is it because deductibles are just one component, right, of your out-of-pocket?
That's right. We've got a bunch of different slices of this. Okay. This is just deductibles. We know by the same folks that did the study, they ranked states by the proportion of households that had high out-of-pocket costs generally, and Oregon was fourth on that ranking.
Okay, so that's all right. Thank you.
Costs are growing. CMS projects healthcare costs out in about 8-year increments. They're projecting it'll grow 4.7% per capita for the next 8 years, at which point it'll be just under 20% of GDP, and costs have been growing in Oregon proportional to that. So from 2010 to 2016, this shows what's been happening with some of the other out-of-pocket costs. You can see income's grown 15%, average family premiums have grown 25%, annual deductibles have grown 77%. So when we talk about sort of there being an unsustainable rate of growth, this is really the challenge. Oregon's healthcare spending grew at the fourth highest rate from 2009 to 2014. You can see the national average was 3.14%, and Oregon was fourth highest at 4.42%.
Does this include everything, Medicare, Medicaid, and commercial? All in? Do we know?
Phone in a friend with Zachary, yes.
This is all in. Thank you.
We ran, actually for the first time, we ran total spending through the all-payer claims database from 2013 forward. So the last chart was just up to 2014. And here you can see general inflation is the bottom line. National medical inflation is the middle line, and the top line is healthcare spending in Oregon. Healthcare has been growing about 6.5% per capita based off of the claims that we have in the all-payer, all-claims database. And when this is just another slide, when we talk about sort of unsustainability, particularly as it relates to economic wage growth, this shows another slice of income versus premiums. The bottom line is personal income growth. The middle line is family premium growth, again for folks on worker or employer-sponsored coverage. And the top line is worker contributions to those premiums, so another addition out-of-pocket costs. Family premiums grew 3 times faster than income from 2000 to 2017. Worker contributions grew 4 times faster, and as we talked about earlier, deductibles grew even faster than that. So why are costs so high? There's no one single reason. We've got a very complex, fragmented, complicated healthcare system. We know that there's lots of opportunity to tackle waste and inefficiency. We know that there's lots of opportunity to improve care coordination. We know that there's lots of challenges with new drugs and new technology, and lots of administrative complexity. There's all of those things. But there's one leading indicator. Hickory.
Welcome, Craig.
Thank you.
There's one leading indicator, at least for what's the top driver of cost growth, and that is price, unfortunately. In Oregon, this looks at this is a healthcare database of the major insurers in the country, and compares the Portland metro area prices and utilization compared with other metro areas, and you can see here that overall prices in the Portland area are 18% higher than the national average. Utilization is a little bit lower, but we've been seeing this shift over time. It used to be utilization was 8% lower and price was 8 or 9% higher, but it's shifting, and utilization is no longer sort of counteracting the price increases.
So can we just get clear on what this data actually means? Maybe other people have the same question, but generally speaking, the prices, provider prices in Medicare and Medicaid are roughly the same around the country. I mean, they're a little higher and lower in some places, I know that. So is this all about the commercial prices?
This is commercial prices.
Only commercial? Okay.
Another slice on commercial prices, it varies significantly. So for 4 years now, we've been putting out a hospital price variation report based off of the top 50 inpatient and top 100 outpatient procedures. And this just gives you an idea of the variation. For a normal delivery, it can range from $5,000 to over $20,000 for normal delivery. A colonoscopy can range from $1,000 to $7,000, again, just commercial prices. And this varies wildly depending on which facility you go to. So one facility might be the highest for delivery and the lowest for the colonoscopy, and it switches for other procedures. Looking forward, the challenge ahead of us, so I mentioned CMS does projections of cost growth in 8-year increments. When they look out over the next 8 years, we do have an aging population, but they actually are showing that 50% of what they're expecting the total growth in costs to be related to price increases specifically. So demographic changes, use and intensity are make up less than half of that. So what's the proposed solution? And hopefully folks know this because that's why you're all here. Overall, this is really about, in essence, setting a budget target for healthcare in the state that would apply statewide across all markets. It's in essence, a cost growth target to measure and hopefully reduce healthcare costs on a per capita basis, measuring total healthcare spending as best as we can, and basically level the playing field in essence by holding all markets to the same growth rate. The idea is to set a target that's based off of a predictable, sustainable rate of growth that's tied to an economic indicator that changes this trend and brings healthcare costs more in line with wage growth and general economic growth in the state. And there's lots of different potential indicators that we can look at, but the overall idea is to stop this trend where healthcare costs and out-of-pocket costs are far outpacing wages in the economy. We'll now be the fourth state to do this. Massachusetts was the first, and we'll talk more about that in a little bit. But since we started on this path and started, there was a task force that provided some recommendations that basically set this up. About the time that task force was winding up its recommendations, coincidentally, 2 other states launched this, Rhode Island and Delaware. So we'll now be the fourth, and are really lucky to have Michael and Megan, because they actually were the consultants who helped Rhode Island and Delaware just work through this process. So they have all the answers for us, or at least they know where the tough decisions are going to be. We're not new to this concept. We've been doing this in the state healthcare programs for the last 8 years. Started with Medicaid and our 1115 waiver that we received in 2012, where we committed to a 3.4% cost growth target, and that was to bring healthcare costs of Medicaid, the growth in healthcare costs on a per capita basis, down to 3.4%. If folks aren't familiar where that magic number came from,
Right here. That's where the magic money came from.
CMS projected at the time that Medicaid costs were going to grow at 5.4, and so we basically made a commitment to reduce that by 2 percentage points. We've since extended that same target to public employee plans. Collectively, between the Oregon Health Plan and PEBNOA, that makes up 1.3 million lives in the state, or basically 1/3 of the state. So 1/3 of the state is already on a state or is on a healthcare cost growth target. Just to kind of give you an idea how important this is on the state side, and I think an example of how we've really committed to tightening our belts. If you compare the 3.4% to CMS's 4.7%, just over the next 2 biennia, that's $2.2 billion of savings and $700 million of general fund. So put it differently, we've sort of jumped off the cliff on the state side and said, we've got to figure out how to hold at 3.4%, even though we know underlying costs are growing faster than that. Otherwise, we're going to have to go back to the legislature and find $700 million more general fund. The challenge is there's no similar budget target on the commercial and self-insured markets, and we know that provider and insurer negotiations by themselves are not keeping healthcare costs in check, especially in parts of the state where we've got highly consolidated markets, and most of the state is considered a highly consolidated market, and the negotiating dynamics by themselves are not keeping healthcare costs in check. And so without some mechanism to put downward pressure on healthcare costs, we'll just continue on the trend that we've been on, which is healthcare costs will keep growing at 4.7% or maybe more, and a larger share of those costs will be shifted to consumers. So what does this mean for health plans and providers? The idea is that the target's an expected ceiling on a per capita basis at a statewide basis, an average statewide basis. But health plans and providers and the state as a payer and policymaker would all be expected to collectively take action to figure out how to meet the target and not exceed the target, both on a statewide basis and on an individual market basis. OHA will measure performance and annually report on whether we're meeting the target on a statewide basis, and then would also measure insurers and providers and identify those that are exceeding the target themselves. And then I think most importantly is really bringing together all of our data and information and creating a sort of common understanding of where costs are and where the cost drivers are. So what's the logic model and will it work? So plans and providers in the state will, as I mentioned earlier, the idea is to take action, not to just sort of set the target and be done with it. The idea is to take action and to really get insurers and providers working together to figure out how they can meet the target. The idea is that from a logic model is that there's sort of a carrots and sticks, and the carrot is transparency and hopefully a commitment to meeting the target and a little bit of maybe fear that we'll start to shine a light if folks aren't meeting the target and costs are growing. And we'll do that through annual reporting and better public information and trying to really align policy efforts to help get there. And then the stick comes in later, which would be if folks aren't meeting the target, then what accountability enforcement mechanisms would we need to deploy? So what's the evidence of this working? As I mentioned, Massachusetts started this in 2012. At the time, it was really in response to really rapid provider consolidation that was occurring that was driving costs up. They have, their target is statewide, applies to all markets. They estimate they're capturing about 90%, I think, or more of total spending that they can find in the system. And at the time, they had the fastest growing commercial premiums in the nation. And I'll just show you what this looked like. The orange line kind of looks right on here was percentage changes in annual premiums on the commercial side, and the red line is Massachusetts, blue line is national average. So you can see they were well above the national average, as high as 10% and even above 10% leading up to them implementing this target. They implemented it in 2012, and you can see pretty much overnight, on an average basis, they immediately fell below the national average and have held to that and have held to their target. And talking with them, they haven't made the target every year, and they haven't made it in every market or with every insurer or provider, but when you average it across all of those, They have met the target, and they have stayed well below the national average in terms of cost growth.
And just to be clear, this is based on total per capita spending, not just premium trends.
That's right. So premiums,
Plus
premiums
out-of-pocket
plus
spending. They don't get there by buying the benefits down and having a lower premium, because that just raises out-of-pocket spending.
It's total
Total spending. Very good.
And real quick, in Massachusetts, they have more destination healthcare, I assume, than Oregon. I'm just making an assumption of what's going on there.
Destination healthcare, what do you mean, Jordan?
Well, I mean, they've got, prominent hospitals in
Oh, yeah.
Boston that others are traveling to from out of the state,
Yeah.
right?
I
So
guess
how
that's
do you
true.
track on a per capita healthcare spend?
I'm gonna turn this. It's a good segue for me to turn it over to Michael to talk about.
So there's a lot of destination healthcare, but that's not included in these calculations. So the person who flies from Saudi Arabia to go to Mass General, that's not included in these spending calculations. These are spending calculations for residents of Massachusetts.
Okay.
All right. And, thank you, Jeremy. That was really well done, actually. Are there
You sound
comments?
surprised.
No. Just keep getting better at it. Are there other comments? I mean, I've got a question. I guess I'm struck by slide number 18, and I just want to kind of call it out, I guess, because I find it kind of shocking, to be honest. I've always known that healthcare prices, provider prices in the East are generally much closer, I'm talking on the commercial side, are generally much closer to the Medicare fee schedule, but typically utilization is quite a bit higher there, so spending can be high. But I guess I'm curious to know, I would ask Angela or Ken or Craig, you all run plans that operate in different markets. When you look at this price point on price number 18, yeah, thank you, and we'll get to yours in a minute. Does this square with the provider prices in the commercial market that you are paying in Idaho or Washington State or Utah, as an example? I'm trying to look at you because I know you operate in those states.
Right.
How does this, is this
Now, I know
consistent?
It is
Microphone.
consistent, oh, sorry. It is consistent from a general messaging. In other words, the pricing is higher and the utilization is slightly lower, but I couldn't specifically state to those percentage points, right?
Yeah.
Relative to an Idaho or to Utah. And I think it also varies greatly depending upon the marketplace. So in Idaho, where you have a highly rural population and not a lot of competition within the hospitals, you'll see a lot of differentiation within this as well. On a different question, and maybe Jack, you want to hear other people's response, but I have a question and was struck by this slide as well, and that is, if median prices are continuing to go up, does that impact utilization? And as pricing goes up, does utilization continue to decline? We don't have to answer that right now, but I think that might be something.
We might get to that. Did you understand that question? I mean, is that something that happens in Massachusetts as an example?
Yes, I don't know that's been studied, but way back to the RAND health insurance,
Yeah.
we had studies in the 1970s. We know that as consumer out-of-pocket spending goes up, utilization goes down.
Right.
Utilization of both needed and unneeded services.
Right, which creates its own
Right.
Set of issues.
reverse
Yeah.
dynamic here, right, as well. So, sorry, Jack, I took you
Yeah.
off topic.
All right, Craig, do you guys have any comments on this, or is this consistent with what you might see in your other parts of the country you operate in?
Yeah, so the other state that we operate in is Alaska.
Oh, that's hot.
So,
Yeah.
so Oregon looks pretty good.
Look, okay, there is a state that is higher than Oregon. This is good to know.
Yeah, but this is consistent with what we saw in the previous task force, and there may be something related to utilization, which is if you're reducing lower value services than the ones that you are doing, or higher value, higher costs, so that may be some relationship there.
Okay, all right. Ken, any comments?
Jack, I think my comment's similar to Angela's. The data are kind of muddy. I think it's less about state differences as it is by market differences.
That's right. Yeah, right.
So,
okay.
And not necessarily rural versus metropolitan. I mean,
Yeah.
there's just different forces in different markets that push the data in different directions.
Okay, very
Which
good.
is an indicator of how complex it is, right?
Yeah, exactly. Okay.
Jack, I do have a question.
Please.
sort of similar to what you were asking about the Massachusetts data. So in the, maybe in the interest of making sure that our facts are, what we know is correct. So in the PEB and OEB data, does the 3.4% represent what essentially the state and school districts are experiencing, or does that get the total cost? Are we seeing some shift in benefits?
Well, it's overly complicated, unfortunately.
I think that's going to be a common comment.
Yeah, so this is a little different than what's been applied in PEB and OEB, because PEB and OEB there's two of them. So I believe one of them is at total spend from a budget standpoint. So it's dividing the budget by per capita, and then the second one is premium growth. But premium growth is a little complicated because you have dependents, and so it's similar to this, but it's not quite exactly the same as taking a true total cost of care.
Other comments on the first set of slides before we turn it over to Michael and Megan for the next set?
Could just add one more comment.
Please.
I'm curious if others from the 419 task force want to weigh in. I can't remember if we added on the agenda any kind of debrief for transition or thinking of why we ultimately recommended this approach, and there's several folks that were on that task force. But even though price is the largest of many challenges, I think there was a strong recognition that if we only pinpoint one part of the healthcare system, then we're going to allow costs to grow up in other places. And I drove up to Astoria on Sunday, and I was listening to Pandora. I heard ads from one of our local hospitals, I think 15 times, encouraging me to visit their emergency room because of low wait times. And I think that's the challenge that we saw with the original task force, is if we just tackle utilization, if we just tackle price and not total cost of care, then we just run the risk that costs go up in other parts of the system.
I don't imagine that was a Kaiser hospital, Jenny, doing that advertising.
Well, I think it's a very important thing to point out in terms of in this period of 2010 and 2017.
Could you speak up just a little bit? Yeah.
Think about a lot of legislative impact. Medicare rate was cut, MA plans.
Yes.
And ACA rolls out, which triggers the HIF fee. So there's a component of a large cost shifting within the healthcare sectors in the payer mechanism that it's difficult to just put out a commercial look itself. It's the more downfall for any other things goes with it.
Correct.
That's why this forum is important.
Yeah.
Otherwise, we just continue spinning up the cost shifting and squeeze the balloon from the other side.
Yeah.
But let me give you one more data point. Kaiser has 8 different regions across the U.S. Territories.
Right.
When I moved here 7 years ago, the Oregon region, Northwest region, does have the highest cost per diem.
In commercial or across the board?
All together.
All together.
Medicaid, Medicare, all that. So it is a very complex issue when we talk about the price.
Okay.
I think the real components get underneath that into the cost, which I think if this collective body really can tackle the real issue.
Yeah.
Otherwise,
Terrific.
we are doing the same thing.
That's great. Well said. And you made a comment. I just want to clarify.
Can I?
Please, yeah. Go.
Oh, sorry, thanks. I had 2 requests, actually. One is the slide that talks about out-of-pocket costs, if we could compare that to income growth. And then the second request that I have is, I think it's slide 15. I'm a little bit confused about what slides are which, but if we could break down the total cost by area. Is it insurance? Is it pharmacy? Is it hospitals? Is it what are the healthcare sectors where that growth is happening?
Yeah, I think we can do that.
You want to comment? It sounds like we can do that, but not right this minute.
Yeah, we've only taken the total the total cost on the all payer claims database, but we certainly could try to break that down by major service categories.
Okay. Maybe that's a TED do for our next meeting.
Yeah, sure, that'd be great. And
Okay.
then Felicia, what was your first question on the income growth?
I think that there was a cost on out-of-pocket costs for individuals. And so I think it would be good to look at that as part of income growth in our state.
Yeah, we'll go back and do some digging around and see what we can find on that.
Okay. Just quickly, Jenny, did you say that the Medicare Advantage rates that are coming in now for 2020, you say they're going down?
Now, the 2020, actually, the final notice, it went up, but
Went up a
in
bit.
this, from a 2012 to
It's
2017,
been
that period,
flat or lower.
they had a pretty big dip, which caused the
Okay.
whole reshuffle.
Okay, thank you.
So other peers
That makes sense.
experienced that.
Okay. Any other comments for this part of the agenda? Okay. Michael, we're going to turn it over to you and Megan.
Okay, so for this next part of the agenda, Megan is going to provide you with a description of how cost growth targets work in other states, featuring Massachusetts. We'll have opportunity to talk about Delaware and Rhode Island at other times, but Massachusetts has been doing this far longer than anybody else, so we're going to focus on them today. Megan?
Okay, so we, as Jeremy said, we have worked in a couple of states on this very topic, and while he jokes that we have the answers, we don't. It is very important to know that you, this body, will be designing this particular policy, and you have the answers. We can just tell you where some trouble spots are and can help you understand where some challenges may be. So it's very important to know that the states that we've worked with have been designing them to fit their own policy environment, to fit their own healthcare environment. And as many of you know who work in other states or have businesses in other states, there's really a lot of variation in state healthcare marketplaces. But we will share today some information on Massachusetts, and then we do have the benefit of having had provided technical assistance to Rhode Island and Delaware, and are actually now currently collecting their data and beginning to analyze it, and so we can provide some of that perspective. In Massachusetts, some of you may know that the legislature has been very active, and actually the executive branch, in creating healthcare policy. In 2012, the legislature, through what's called Chapter 224, created the Health Policy Commission, and it also created the Healthcare Cost Growth Benchmark. It's called Benchmark in Massachusetts. I think here the terminology is target. And the Health Policy Commission had a couple of goals, similar to OHA in the sense, the Oregon Health Policy Board. It is a board of advisors appointed by the governor. It is a quasi-independent entity, and it was tasked with 4 main functions. One was setting the target, and then 2 were related to delivery system and payment reform, and the 4th was to correct market error. And they do that through some soft regulatory ways. But with respect to the target, they were charged with creating the target and monitoring it on an annual basis. And they really did that, I think, as Jerry mentioned, because the costs in Massachusetts were known to be very high. Previous legislative initiatives have given powers to other agency branches, including the Attorney General, to collect some data, and so they knew that there were some serious problems with the costs in Massachusetts, and that's how this policy came about. One quote that I actually like from Stuart Altman, he's the chair of the Health Policy Commission, he's a healthcare economist and is based at Brandeis University. Some of you may have read some of his work over time, but he said this is the right balance between appropriate rule of government and letting market forces have a shot at developing a more efficient system. That was sort of his viewpoint on the healthcare cost growth target benchmark. Next slide. So in Massachusetts, they are measuring the total healthcare expenditures for Massachusetts residents. And it has 3 main components to it. One is all medical expenses paid to providers by private and public payers. So Medicare, Medicaid, and any private commercial insurer. It includes the Medicaid Advantage Care Organizations, includes Medicare Advantage, and it is sort of an all-in figure. It also includes all patient cost-sharing amounts, the deductibles and co-payments, which I think is an important piece. And then finally it includes the net cost of private health insurance, which is essentially the administrative expense of running an insurance company, the operating margins or contributions to reserves, depending on whether they're for-profit or not. And all of that gets rolled up into a per capita figure measured at the number of Massachusetts residents.
Is long-term care in this too?
Yes.
All long-term
Yes.
care? In SNFs?
Yes.
Okay. It is. All right, good.
Question, does it also include self-insured payers?
Yes, yes. Yes, actually, that's a key feature in all of the states that we're working with, that self-insured data are included in this, which is a huge percentage of the market in many states. The Center for Health Information Analysis, this is the CHIA, it's fondly called. They sort of like to think of themselves as the agency of record for all Massachusetts healthcare information. They collect a lot of different data, including data to support their benchmark work, but also they have the all-payer all-claims database, and they have required for years, the legislature actually has required for years, hospitals and payers to provide different information to CHIA and its predecessor agency. And so on an annual basis, CHIA reports lots of different things related to the benchmark, but also generally to cost and cost growth in Massachusetts. And so this is just one example of a recent report. But the next slide, please, Michael. What I find most interesting is when they report this information, they're able to really break down where some of the growth is compared to their benchmark. And you can see on this slide, they've broken it down by key service areas, which I think is what the request from Felicia was. They have hospital, inpatient, and outpatient. You can see its growth on a percentage basis from year over year. Professional services, pharmacy, gross and net of rebates, and other medical, other professional, and non-claims expenses. Non-claims expenses, in this case in Massachusetts, as with Oregon, they have a high rate of value-based payment, and these non-claims would be things like pay for performance bonuses or risk settlements for ACO contracts. And that's, I think, an important figure. So annually, the policymakers are able to see what the changes in growth in healthcare, and then also dive in a little bit deeper to figure out where the issues are. If you go to the next slide, CHIA also reports the data at the state level, as you saw, but also at the market level, meaning Medicare, Medicaid, or commercial, and then again at, as you can see on this slide in particular, at the commercial level. So here you can see the reported, the percent growth in spending by the insurers who report to CHIA. And then you can see both their unadjusted spending and their health status adjusted spending on a per member per month basis. And it provides you a little bit more context about where some of the challenges the state faces are through this sort of data.
So what are those giant numbers?
That would be the growth in spending.
Well, you can see in some of these cases, these are new entities or they are small entities. So for example, 107%, their member months grew 106%.
Right.
And so there's a mixture here of very large payers. So Blue Cross Blue Shield is the market leader. Those numbers are going to be much more statistically stable. Harvard Pilgrim Healthcare and Tufts Health Plan are the second and third largest plans. But some of these plans are very small and their enrollment either rising dramatically or plummeting.
Yeah. Health status adjusted spending is risk adjusted in the aggregate for each plan?
It's a risk-adjusted spending by the payer's own risk adjustment methodology.
Okay.
And so you cannot compare the risk-adjusted rates across the payers in Massachusetts for that reason.
But is there some kind of certification on the risk-adjusted methodology by payer? Does the state have to say that?
The state asks that the payer reports what tool they're using.
I see.
But there's no sort of
single
audit.
common tool, okay.
Right, and there's no common tool.
Yeah, okay.
That was actually, in talking with folks in Massachusetts, I mean, that was kind of one of the design details that they had to work through was, did they want to have everybody use the same risk adjuster, or do they want to let folks be autonomous, and they landed at being autonomous. But I mean, I think those are the types of decisions that we can make as a
We're
group.
going to have to deal with that here. Yeah. Yeah, good, okay.
As we talk about growth rates, similar thing comes to mind in Oregon with property taxes. You had some counties with low property tax rates, some counties with high property tax rates, and then a growth rate was put over the top of those, and we've had some languish as counties over time that were set at a lower rate. Similarly, in this context, has Massachusetts resolved how to deal with providers that may have started out at a lower rate than their peers?
So that's a known challenge in Massachusetts. The Attorney General has done a lot of work on reporting on the variation in prices, and in particular on there's great variation between some of the major players in Boston and some of the players who are outside of Boston in terms of their prices. And this does not get at that. So variation doesn't really change when you're measuring total healthcare cost growth, because you can still continue to grow at 3% or 5%, but you don't necessarily even out the variation.
This is not a disparity reduction strategy, and in fact, if anything, it worsens it. And that's a challenge and something worth discussing. We have not found a state that has found a formula for reducing disparities in prices that are resulting from market dynamics.
But just to be clear, as states become more transparent in their price points on the provider side, and more specific about which providers have higher price points versus lower ones, is the inclination for the lower ones to want to move upward, or for the high ones to want to get back into the pack?
Oh no, the low ones want to move upward.
Okay, so that's just so we're clear. Transparency is a double-edged sword, is what you're saying.
Mm-hmm.
Yeah, for sure. Yeah.
So as we saw from an earlier chart that Jeremy shared, this is just the annual growth in the total healthcare expenditures on a per capita basis from 2012 to 2018. The orangish line here was the target. It was set at 3.6 for 5 years, and then it lowered to 3.1, which was a design feature that the legislature had. It did give the Health Policy Commission some say over whether or not it should be lowered, and they agreed that it should be lowered. And so you can see it lowering, and as Jeremy shared, they have not met the target every single year, but on average, over the number of years they've been doing it, they have met the target.
And Megan, who is responsible for setting the growth target every year?
The Health Policy Commission. They have some guidance from the legislature on exactly what and when they can do so, but as they go out further away from 2012, they have more control over the target.
And would we envision, Tina, in Oregon, that our Health Policy Commission would take on that responsibility?
Well, I think that's probably a recommendation out of this group.
Out of this group?
Yeah.
Okay. My other question, does this group also, are we also responsible for the actual number arriving at the target?
Yes.
Okay, we'll get to that at some point.
So I'm not sure I have my facts straight, but in this time frame, did Massachusetts pass a law mandating plans to offer tiered plans where the higher cost providers are on a second tier? Is there something that occurred like that?
They did. I have to say that it did not have a lot of market impact.
Okay, thanks. Good question. Okay, thank you.
So what's driven success in Massachusetts? One, I think, is that there's been a common goal. This conversation about the target has been at many different tables in the state, and everyone is focused and knows what the goal is. And I think that's a very important feature, that there's really been a common target that applies to all payers and all providers in the state. It takes a total cost of care approach, meaning it looks at all spending. It looks at the out-of-pocket spending as well, which is akin to the total cost of care contracting, which is very popular in Massachusetts in particular. And so that aligns with the same sort of mentality. Importantly, it really has had an influence on negotiations between payers and providers. We have heard and it's been reported that payers and providers are sitting down at the table together, and the benchmark, 3.6, now 3.1, is really the starting conversation. And that's really been one reason why Massachusetts has been very successful. And then finally, transparency. Transparency has been very successful in Massachusetts. One reason is because there's rich data sources, and the state has well-supported agencies that can publicize the data. But also, the Boston Globe Spotlight has literally had healthcare cost growth as a spotlight feature article over many years. And so regular citizens in Massachusetts who read the Boston Globe will pick up the paper and can learn more about it. And so there's been really a lot of reporting that has helped the state in really bringing these issues to the forefront.
So can you say something about kind of the insurer market there? And so I'm thinking of the alternative quality contract, the blue contract. So I know that a lot of providers came into that. So you know, if that was a huge chunk of the market, you might think, well, some of this cost is coming down because of they're paying things differently. But there's other payers here. So what does it look like in terms of market share for some consumers?
So you know this probably better than I do. Blue Cross is about 30 to 40% of the commercial market.
No, they're much more. So all the major commercial payers are all contracting for HMO commercial products using total cost of care. It's the standard way everybody contracts. For PPO, it's a little bit mixed. Now, Massachusetts is a high HMO state, much higher than most other states. So about half of the commercial market will be in an HMO product. And so it's mixed in the PPO market. The insurers have been introducing this, but whereas in other states, commercial contracting on a total cost of care basis started with PPOs because there was no HMO, it was the opposite in Massachusetts.
But I think your point, John, is a good one, which is we don't really have a single dominant payer, last I checked, that has 70% market share with a quality, value-based incentive payment that could drive down total cost of care spending. So we're going to have to work through that a little bit. I think that's your point, yes. Yeah.
Jack, I have a question.
Yeah.
When we think about the time period and what was going on nationally with the ACA, and even though the beginning years were, you know, a little problematic, waiting for the Supreme Court and other things, is there anything to suggest that the national agenda influenced this work, and if so, as a driver, or in what ways?
I don't think so, no. This was a very state-specific strategy. Now, Massachusetts did coverage expansion before the ACA, and as you know, was something to be a model for it.
Right.
And so I think there was a resolution within the state. We covered the coverage issue, we took care of that. Now we've got to focus on healthcare spending.
Okay, thanks.
Do you know if anybody's done any analysis, like on partners, that Mass General and all of them, on their revenue? I mean, have they shifted significant costs to out-of-state, out-of-country payers?
So we don't know that. We do know, though, that they have brought down their spending growth rate. They're still super high expensive, but they have brought down their spending growth rate.
Their rate of change.
Yes, the rate of change has slowed.
Yes.
And containing cost growth has become a priority for those organizations. They were the ones, as Megan indicated, that were really called out in the press, and I would say publicly shamed, and so they have a lot of motivation to do so. Yeah. But you know, have they increased the charges elsewhere? We don't know. We do know, though, that in the case of Partners, which is the has been the largest system in the state, that they have pursued a growth strategy to expand to neighboring states, perhaps as a way of finding opportunities for economic growth.
Shame can be a powerful tool, yeah.
Question,
please,
Michael,
Shane. Yeah.
could you remind me, is Massachusetts have the lowest insured population, right?
Yes.
I thought they are. Are they passing legislative action around the mandate?
So there's been a mandate in Massachusetts for a long time.
Since Ron.
Yeah.
So they kept that way pretty much after the whole
Yes.
episode.
Yeah.
So that's important.
Right, so there's a very small percentage of people in the state of Massachusetts without any coverage.
It's like 2%.
2%.
Yeah.
Do we know what it is here offhand?
6.
6. Thank you. And finally, we are blessed to have a real actuary. Jenny, are you an actuary too? Or anybody else?
I work there.
Okay. Did you play one on TV once?
No.
Well, I know that Craig is a real one. And so at some point, Craig, we're going to have to get your wisdom on, in order to, if we hit a 3-4, let's say that's the number, we'll decide that at some point. What percent of that is, generally going to be utilization and intensity, and what percent is sort of unit price? And we're going to have to understand that formula a bit, right?
Yeah. But I think the total cost of care approach takes that into consideration when you're doing that negotiation.
Oh, yeah.
Yeah, if it's just a unit cost at the target, then you're missing a big piece.
You're missing, yeah, exactly. Okay, so we're going to have to deal with both. You have a comment?
Yeah, I have a
Please.
question.
Yeah.
Actually, I like the method that you used that was on, I think it's slide 34. Where you really, it doesn't seem like you're looking at premium, but the administrative cost from the payers. So you're looking at their costs from the all-payer claims database and then the administrative component. So I think that's good. Curious though how you've handled taxes and fees, because the ACA fee I think has come in and out during that time period, and curious.
Okay, so first, we don't want to take ownership of this. What we're describing for you is what Massachusetts did.
Okay.
We did not create the Massachusetts methodology. We've studied it greatly because we used it to share with Delaware and Rhode Island, and they used it as a reference point, but this is not our methodology, just so you know.
Okay.
Okay. Megan, do you want to talk about taxes?
So I should know this since I have read that methodology forward and backward a million times, but particular taxes and fees I do not know, but we can look it up and get back to you.
Yeah, I'm curious. Maybe it's something we need to consider in this commission, whether taxes are.
Yeah, I think that's going to be an issue. Yeah. We need to kind of move this along. I know we're almost at break time. Megan, you had a couple more slides?
I think that there's one more slide,
Okay.
if I'm not mistaken, and just to share what some policy experts in Massachusetts have thought about the target thus far. I think we've shared some of these in some of the things that Jeremy and I have said already. But there's generally been some agreement that this has been an effective policy, and that it is working, and that there's been general agreement that everyone has been thus far satisfied with it. So there's some quotes from the Health Policy Commission Chair, David Cutler, who's also a Harvard healthcare economist, and you can read those on your own, but generally we just would say that folks believe that it is working in Massachusetts, which is why other states have begun to examine it as a policy for themselves.
Yeah, terrific. Well, first of all, it's wonderful to have the two of you with us for this, because your expertise in observing how Massachusetts and other states are doing this is invaluable. So thank you very, very much. Are there any comments before we take a 10-minute break?
I have one, Jack.
Please.
And that is to say, the environment in Oregon is not as it was in Massachusetts in 2012.
Okay, can you explain that a little more?
Well, we've talked about how there was huge public attention to the high prices and market power of dominant hospital systems, and they had been called out on the run.
By the press, by the governor, by whoever.
Right. There was also a very high level of total cost of care contracting that was present, at least in the commercial, and even then, early on in Medicare with Medicare Shared Savings Program.
Okay.
And so those were factors that heavily influenced this policy and its impact.
Okay.
And so I think as we think about how might this strategy work in Oregon, we have to think about what's the environment here and what might be necessary for this approach to succeed in Oregon, because it may not be the same factors that led it to be successful in Massachusetts.
Okay. We're going to need to examine that a bit. We don't have time this moment, but I'd like to dig in on that and know exactly what you think that was and how we might generate that level of consciousness, for lack of a better term. That's great. Okay. Why don't we take, it's 10:28. I'm a stickler for these breaks. So why don't we take 10 minutes and get back here at 10:38 and we'll continue, okay? Thank you. Okay, folks, we're going to get started again. Thank you
No matter what you
very
say.
much. Jeremy had a quick comment to make, and then we'll get started on our second half of our agenda.
For folks in the back of the room, we do have a public comment period at the end, so if you are interested in public comment, please sign up right by the door, and we'll have public comment periods each meeting as well.
Okay, any comments on the first part of our agenda before we lean into the charter and what this committee is really all about? Okay, all right. Well, it looks like Michael and Megan, we're going to be leaning on you the rest of the agenda.
Yeah,
So
it's my turn to
get us
lead.
through the committee charge, Michael.
I just want to note, none of you asked a question that always gets asked of me, which is, so what happens in Massachusetts if someone doesn't hit the benchmark?
Someone meaning a plan or a
Plan
provider?
or a provider. Providers get measured too.
Okay.
Not reported quite as publicly.
Right.
And the answer is pretty much nothing.
Okay.
Which is what makes their success fairly remarkable. There is an authority that the Health Policy Commission has to require entities, be they providers or payers, to come forth with a plan if they've exceeded it.
They have to do that in a legislative committee? Or
No. The Health Policy Commission as a quasi.
Government.
They could just say, you've got to come develop a plan.
Yeah.
But there are no harsh consequences.
Okay.
And it has succeeded thus far without that. I would say that many people, myself included, were skeptical that having absolutely no consequences would prove effective. But thus far it has.
Wasn't the language about the Attorney General being able to call people up to explain things?
Right, but nobody's ever been called up. So
I'll just give a little context, at least from conversations with the Policy Commission staff, which have been, each year they've identified 15 to 20 organizations that are individually above the benchmark, at least for some part of the market. And the process they've engaged in is basically put them on notice, and then basically take the leadership on notice, and then go sit down and have one-on-one conversations with them, ask for data, and try to basically try to understand what's driving costs. And they've sort of applied a reasonableness test, which is sort of, and I don't know if this is written down as in a rule anywhere, but they sort of had is there a sort of reasonable, justified reason why in this particular year the organization was above the target? And each year they have found that there was a legitimate reason for a one-time bump that 1 year, and the conversations have been basically, we wouldn't expect to see this next year, or we might be called before the commission, or we might start to engage in performance improvement plan conversations. But the types of things they've seen have been major changes in patient population, or trying to smooth out reimbursement rates, or things of those natures. They've said that makes sense from a one-time basis, but it shouldn't be a multi-year trend. So.
Okay, so the first half was more about the why are we here, and this is going to be more about how are we going to do this.
Right. So
okay.
We're going to walk through what our approach is going to be over the future meetings. So first, a little bit of how we got here, and some of you know this because you participated in 419. But that body 2 years ago, the task force was required to look at opportunities to limit the growth of healthcare expenditures, generally speaking, with some focus on hospital costs, and to assess specifically the possibility of implementing Maryland's hospital rate setting model, and then to consider alternatives. Through that process, the task force concluded that Oregon should not adopt Maryland's hospital rate setting model, and instead should pursue the strategy that we are discussing through this committee. And as Jeremy indicated, this would build upon the existing target for these three acronyms, which probably most of you know, but for those who do not know, Oregon Health Plan and is the Medicaid program, and PEB and OEB are the public employee benefits programs for educators and non-educators. So Senate Bill 889 created this implementation committee. We are operating under the direction of the Health Policy Board, and you have been given 13 tasks. And so this gets to the question asked earlier, well, so are we setting the percentages? I'm going to go through everything that exactly we're supposed to do. One is determine how to govern the target program on an ongoing basis. 2, to develop a specific methodology for establishing the target, including the economic indicators to be used. So there's no specific economic indicator that was named in the bill, but there is a reference to considering attaching the target in some manner to an economic indicator. 3, consider what should be the initial target, so X%, and to specify the frequency and manner with which the target should be reevaluated and updated. 4, the method by which data will be collected in order to assess performance relative to the target. And that would include at the provider level. Okay, so it's non-specific in terms of what those data should be, who's providing them, but we need to define that for the purpose of operationalizing the target. 5, we are to consider technical assistance and support to be provided to providers and payers to help them remain at or below the target. So some of these features are common across all of the states and others are not. This is a distinctive one, this provision of support to ensure success relative to the cost growth target. 6, you are to identify opportunities to leverage existing resources to provide that assistance and support. 7, this is a comparatively general directive. As a body, you are to recommend approaches for measuring quality of care that accounts for patient health status and aligns with the work of the Health Plan Quality Metrics Committee. For those of you not aware, the Health Plan Quality Metrics Committee was created by the legislature 2 or 3 years ago now, and it is responsible for defining an aligned quality measure set across the Oregon Health Plan, HEB, and OEB. Okay. It does not have jurisdiction right now beyond the purchasing done in those 3 public programs. And so the directive here is to think about measuring quality. So it's a somewhat less precise directive than some of the others that you have.
It does apply to the marketplace as well.
Oh, I'm sorry. Thank you. I forgot about that. 8, we are to consider opportunities for lowering costs and thereby beating the target by using innovative payment models for all payers. So this is also quite different than just establishing a target. And what we are planning is that in the course of our work early on, we're going to focus on the target methodology and then move on to some of these somewhat separate supporting initiatives. 9, recommend a system for identifying unjustified variation in prices or in healthcare cost growth, the factors that contribute to the unjustified variation. And then 10, to identify payers and providers that should be required to report. So number 9 speaks more broadly to what we internally have been referring to as a data use strategy, or a strategy to supplement the cost growth target with analysis that identifies what are cost drivers and cost growth drivers in order to inform both private and public initiatives, individual and aligned, to attain performance levels that are within the cost growth target. So these are supplemental analytic activities that are intended to help inform and support target attainment. 11, we are to discuss accountability and enforcement processes that may be phased in over time and could include compliance measurement, procedures for imposing a performance improvement action plan. This is similar to the Massachusetts approach that I just described, or other escalating enforcement actions for when a provider or payer fails to fall below the target. Measures to enforce compliance with the target for programs administered by OHA and DCPS. And then 12, to make recommendations regarding reporting of data. And you can see there's a lot of detail here. But all of this is for reporting, including to the Legislative Assembly. I'll also note that the reporting of data includes here an annual report and public hearings. The annual report and the public hearings are both features of what Massachusetts does. There's an annual report that comes out every fall in Massachusetts, and it's followed by 2 or 3 days of public hearings. And those are the hearings that Jeremy just attended a couple of weeks ago. So you will make recommendations regarding reporting generally, but also specifically in terms of an annual report and the use of hearings. And then finally, last, we will be discussing an implementation timeline. Our target, however, is to establish a healthcare cost growth target in 2021. So that is for January of 2021 for assessment of performance in 2021 and reporting in 2022. Reporting in 2022 because there's claims lag and payment lag. So in fact, we won't have 2021 data until well into 2022, and thus probably reporting on 2021 performance in the latter portion of 2022. Does that make sense? Okay. So this is a pretty broad legislative charge you've been given. This is why we're meeting for a year and not for 2 or 3 months. And we're going to try to move over the course of the meeting sequentially through these topics, so we're not talking about all 13 of these at the same time.
Yeah, good.
Right?
That's a good thing.
Yeah, and there's a natural flow to some of them. So things like consequences for non-target achievement, those are things we're going to push off until much later. As Jeremy indicated, we've provided you with an estimate of what we think we're going to talk about when, but we don't know yet what the dynamics of this body are going to be and how much you will want to discuss individual topics. So after we get a better sense of what the culture will be of this group in terms of how it does its work, we may modify the schedule accordingly.
But generally speaking, Michael and Jeremy, this work that we're about to undertake needs to be generally wrapped up by next fall with a full set of recommendations along these 13 areas that we submit then to the governor's office or to the legislature or to OHA? How does that work?
So first, it's recommendations to the Oregon Policy Board for adoption.
Okay.
And then the report goes to the legislature by September.
By September
of 2020.
Okay.
Yeah, so less than a year.
Less than a year.
So really, we're looking at probably needing to have a draft of recommendations before the policy board. And we'll do updates to the policy board throughout the process.
Okay.
Because the goal is to have them, have this land in a place where they can adopt it. But nearing the end of recommendations in July, have August to finalize things, to really get the report to the legislature in September.
Okay, that's a lot. So
Yeah.
I would just say to the senior staff and our consultants here, you just be sure to be pushing us. And if you feel like we are squandering time and energy, I'll try to call that out if I see it, but don't be shy because you've been through this before.
We do think this is achievable.
Okay, good.
Okay. While your scope is broader than what some other states have had, you also have afforded more time for it.
Okay, good to know.
So we are envisioning these 13 charges as falling within 5 work streams. This is just to simplify it all for you to keep track of what we're doing. The cost growth target has been our focus this morning and probably is the highest profile and most important focus area, and we will begin to delve into this in earnest in our next couple of meetings. Quality and equity, this is the broader charge around measurement that I just described. The data use strategy is how to tap into the all payer, all claims database and other resources to obtain insight that can be made publicly available in terms of what is driving cost growth, cost variation across the state. Transparency and accountability, that's all the reporting tasks that we just talked about. And then taking action, which really speaks to what can be done to facilitate activity in support of attainment of the cost growth target. I think it's our personal belief that to set a target and publish reports is nice, but perhaps not sufficient for facilitating the type of change necessary to achieve the cost growth target.
That sounds insufficient.
Yes, it is insufficient, right? And so taking action is really about, well, so what could be done at multiple levels by individual organizations, by the state, but also through collaborative effort that brings multiple parties together.
Right, good.
Okay, so over the course of our future meetings, to help you keep track of what we're talking about, we will reference not the 13 charges, we're going to reference these 5 work streams. Okay, and let you know which work stream are we talking about in which meeting, so that we don't lose you. And we know that we're only getting together once a month, and so you may not completely remember what we talked about the last meeting, and so we're going to use this as a mapping mechanism.
Yeah, and for the purpose of the rest of the council, of the commission, the chair and the vice chair will be having lots of meetings in between our 3-hour meeting to prepare the agenda and try to move the process along. So we'll try to do our very best to kind of make sure we're on track here.
And this narrative describes the 5 work streams. I'm not going to repeat it, but this provides a narrative description of what we have grouped in these 5 categories. Okay, so next, let me pause now and just ask if there are any questions about your charge. Anybody? Okay, so next I'm going to talk about a draft charter and set of operating procedures that we created for your consideration. We thought it would be helpful to have some parameters to define how we will do work. You have a draft of the Implementation Committee Charter and Operating Procedures. It's not a super lengthy document. It falls a little over 7 pages. I'm going to give you an overview of it today. We invite you to consider it after the meeting and to identify any feedback that you have, to share that feedback so that we can make, discuss and make modifications, and then hopefully finalize it when we meet next month. So let me give you just a bit of an overview as to the charter. It's organized in 7 sections, as you see here. The problem statement was, I think, largely provided by Jeremy in his introductory comments, so I'm not going to dwell on this. The vision and mission, this is important, so I am going to pause here. So the vision for all of this work is to lower the growth of healthcare spending to a financially sustainable rate. It will be your charge to figure out what financially sustainable rate means. Okay, there's no objective definition. You won't find it defined in a dictionary. This is for us to wrestle with. And our specific mission is to establish a methodology using sound principles, and we want to measure as much total statewide healthcare spending as is practical. We will probably never be able to capture 100%, but we want to try to be as inclusive as we possibly can. And then develop a strategy that is appropriate and fair for reporting on performance. And I want to emphasize the word fair because for those of you who may have taken statistics classes in the past, those studies will be relevant to our considerations today. In measuring cost performance, there is a great risk of making inappropriate conclusions, especially when the sizes of the populations being measured are not sufficiently large. So we want to spend time talking this through
Good.
and figure out so what is fair and appropriate for reporting performance. Okay.
Yeah. That's great. Well said.
The purpose of the healthcare cost growth target is that it will create an expectation and accountability for managing cost growth within the target. And that it will also spur analysis that will lend insight into what is driving both cost and cost growth. And I want to distinguish the concepts just for a minute. If we focus on what's driving cost growth, we may not focus on where costs are greatest, because sometimes costs are growing greatest in areas that represent a small percentage of total spending. Okay? So if we only looked at cost growth, I'm just making this up, this is not data informed, but let's say we found that it was highest for pharmacy spending.
Yeah. Specialty drugs, for example. Yeah.
Specialty drugs.
Yes.
Well, specialty drugs as a percentage of total spending is a lot less than hospital spending. So we might not look at hospital spending if we only focus on where the growth was fastest. So we want to focus both on where costs are significant and where they're growing fast.
Yeah.
Okay? Cost drivers and cost growth drivers may not always be the same.
Right.
So that's the distinction I want to make. Anyhow, the purpose of the target is to provide an impetus for understanding both cost drivers and cost growth drivers, and ultimately to identify where opportunities exist to take action. Okay. The charter includes your charge, which I just described, so I'm not going to go over that. And then Section 5 has your duties and responsibilities. And I do want to touch upon what these are for a minute. And you have a handout specific to this. So you have accepted your role here. You have been asked to serve until September 15th of next year, unless you are asked to serve for longer. Okay? And for right now, you will be discharged as of September 15th. Your responsibilities are to attend the meetings, to participate actively in our discussions, to the extent that we share materials with you, to spend a little time studying them. And we are not going to overwhelm you with homework. We know you all have significant responsibilities outside of this body. And then we will want you to participate in the development of the final report, which will have recommendations. So those are the principal responsibilities that you've been given. The Oregon Health Authority, the Department of Consumer Business Services, will be providing you with information and other support to help you do your work. Our esteemed chair and esteemed vice chair will try to facilitate our conversations, especially if we get stuck, and try to help us all to get to consensus decisions and to abide by all of these parameters. And that reference to consensus leads me to talking about our principles. So the principles are how we do our work. So we are working, our North Star is cost growth target by January 1st, 2021. As I said, we want to be inclusive of all populations and categories of spending to the extent possible. A third principle, and an important one, is that the target will be a stable one. And by that, I mean one that payers, providers, and policymakers can rely upon for multiple years. Let me explain why for a minute. So if we establish a target and an organization knows that it will be held accountable to it, but only knows what it will be for the next 12 months and has no idea what it will be for the following 12 months, it makes for a very difficult business plan. Mm-hmm. And so there's a lot of value to many interested parties in knowing what it will be for several years out. And we will share with you from examples of the other states, but Massachusetts, Delaware, and Rhode Island all established their cost growth target for multiple years. There are opportunities in some of the states to revisit them if there's some special something that happens. In some cases, not in all states. But it provides some level of assurance. So in Massachusetts initially, they knew it was 3.6% for multiple years. And then it moved down to 3.1%. But they knew at the outset it's 3.6% for multiple
For 3 years, 4 years, whatever.
Right.
Okay.
So my question, in that context, to support the community, the industry to really embrace this and working on in a little bit longer term than just 1 year, are you aware of any other type of mandate bill and put into place after they establish the cost benchmark, which can, contradict to some extent, allow people to react to those things? Are you aware of those happening in Massachusetts?
I'm sure that there are providers and payers that will say that the Massachusetts legislature took some action that impacted their ability to do it. I'm positive. And this is why, to the point that Jeremy made earlier, in Massachusetts there's an opportunity for parties to sit down and talk with the state about, or the Health Policy Commission, not the State Health Policy Commission, about what happened. But is that an X factor? Yes, I would say no more so than the invention of a drug to treat hepatitis C. So Megan showed the graph earlier where Massachusetts was above for a couple of years. One of the years that it was above was the year that Sovaldi came out into the market. And there was broad consensus that the introduction of that drug drove up healthcare spending across payers and created a blip in spending. That was identified, and people said, okay, that's all right, that's a reasonable cause for us having been over target. So I would say that state legislative action or new medical technology or some horrible flu, or there are all sorts of factors that could create aberrant experience in a given year.
Yeah. So as an example, I was curious, I was going to ask you, Craig, because you're the actuary. There are macro demographic changes going on in our population. I mean, I live in Northeast Portland. I see a lot of young people with funny hair and jewelry in their face, walking around. I mean, do we look, is that part of this scene, is understanding at an aggregate level demographic and disease burden changes happening at the population level? Can we even do that? Does Massachusetts account for any of that, Michael?
No.
Okay. Fine. Then maybe it's just so broad and big and hard to measure it, doesn't really matter, I guess.
Well, we can and should talk about this.
Yeah.
Okay, and including in changing demographics in the population.
Yeah.
Because I think you should wrestle with what does it mean, is it significant or not?
Or not.
The approach these other states have taken is to say, we're setting a target.
Right.
If something weird happens, we'll
gonna
talk about it.
Okay.
But we're not going to get into some nuanced formula.
Right.
That's
some actual, yeah.
Yeah, there's a lot of power to the simplicity of saying, I know it's X point Y%.
Yes, I singing to the choir. Comment?
It seems like those sorts of things would be taken into account when we're setting the target, the demographics, what we expect.
Okay, so that'll be a part of our dialogue.
I would think so.
Okay. All
Or
right.
just the fact that we may have to call out some general examples of where it may create an aberration. I don't know if we can define everything, like you said, a flu. We don't know 3 years from now if there's going to be some significant flu event. But just being able to call it out, I think
Yeah,
is
this is an example of not letting the perfect get in the way of the good.
Yeah, that's a great point. Right.
Okay, good.
Yeah, and this will be an important consideration when we think about potential consequences for not hitting the target.
That's right.
We want to be sensitive to
That's right. Okay, thank you.
So D comes back to being statistically robust in our methodologies, including especially reporting. E, I think Jeremy impresses upon us the need to be sensitive to the impact that healthcare spending has on our Oregonians. F, to the extent that there are other state health reform initiatives going on, we want to think about how this relates to them. and to the extent that alignment is possible, to pursue alignment. G, we want to promote collaboration and encourage collective action to meet the cost growth target. This speaks to the 5th work stream that I showed about taking action and the opportunity to do this not just through individual action, but through collective action. And then finally, in your complex recommendations, realize that Jeremy's going to have to do all the work after it's done. But seriously, we do want to be mindful of what will be the operational financial implications of the recommendations and what will be the resources required to implement.
Very good.
So, Michael, can you make a point of clarification? So for F, does aligning the recommendations with other state healthcare reform mean that the target has to be 3.4%?
Well, I think we already heard no, right? Otherwise, we probably wouldn't exist if that was the answer, right? There would be no need to create this body.
We have to have some dialogue about that, sure.
Yeah, but we will need to talk about the relationship. Okay, and then in terms of the nitty-gritty about how we do things, this is spelled out. Yeah.
Coming back to 3.4%, I mean, I think it is reasonable to think about, is there a reason why 3.4% would be a starting point, just so people are used to it. But I think a bigger kind of connection to broader state health policy would be the 3.4% for Medicaid expired in 2022. And so one of the goals here is to stand something else up that's going to replace that, because when our waiver expires in 2022, so does the 3.4%.
And it was established which year?
In 2012, and then was extended in 2017.
All right, so it was developed in 2011.
That's right.
Okay, which means that it's pretty old. So yeah, even if it is a reference point, one would certainly want to revisit it all these years later. Okay. So for operating procedures, these are spelled out again in the charter that you have. I want to note only a couple of things. As a general principle, and based on today's meeting, I'm sure that this will be the case, but we want to respect one another and respect the process that we're following. In terms of your communications, because this is a public entity, your communications, generally speaking, are going to be public. If you are communicating with a stakeholder body or individual about the work of this committee, we ask that you copy the chairs and the staff on your communications with them, and that you generally be mindful that these are public activities and that has implications for your communications. In terms of external communications, while you may all speak with members of the media, you are encouraged to defer to the chairs and to OHA for public statements about what this body is doing. So there's no muzzling of anyone, but best if they be our spokespeople.
Could I make one clarification just on the email point? In terms of copying chairs and staff, great. Don't copy all, because that turns the email into an actual public meeting, and that's problematic.
I guess, sorry, question on that. So if we're responding via email, that makes sense. If somebody specifically reaches out to us with a question or thought or what have you, copying the chair and co-chair. If you're generally having conversations with stakeholders in the community, we all represent in various formats, how do you want us to handle that?
I don't think there's any limitation on you having those conversations.
Okay.
In terms of our operating procedures, we will be making, or you will be making, many decisions over the course of our meetings. The charter says that the decisions will be made by consensus of this body, and there will be a vote if one of you wants a vote. But our objective is to achieve agreement around the table. There will be a vote on the final report and recommendations at the end of the process, and to the extent that there are minority views at that time, those views will be represented in the report.
Good. Does that seem reasonable to people? Terrific. Yep.
Are we weighing in on these now, or are we hearing them now and then weighing in on them before our next meeting?
So I'm almost
confused about the
done.
process.
I'm almost done. After I am finished, let me see how we're doing on time. Not so well. So I think what we will do is ask you to provide your comment and feedback and questions following the meeting. We'll have a second conversation, or really the first conversation to be honest, at the next meeting. Okay?
Okay, so feedback to you, and we'll surface that at our next meeting.
Yes, feedback specifically to Megan, and there's her email address.
Okay.
Okay, and we will make some modifications based on initial feedback that you might share with us that we think is non-controversial.
Yeah.
If there are things that we think need discussion,
We'll bring it
such as
here.
how we make decisions, we'll
Yeah.
bring it back here.
Okay.
Okay.
Got it, everyone? Terrific.
Okay, so how will we develop recommendations? So our plan is to bring you a series of sequence, design, and implementation questions for the 5 work streams to make this all easier for you. And so when it comes to the cost growth methodology, there are a number of design decisions. For example, which populations do you include? Which services do you include? We will bring them to you one at a time. We will share with you choices that we've identified. We'll let you know what other states have done. And we'll discuss them and then move on to the next one. I think everything else here I've covered. We want this experience to be a welcoming and safe one for all of you to share openly throughout the process. We also want to make sure that stakeholders are engaged. We're not talking a lot today about what that stakeholder engagement process will be, but I'm thinking, Jeremy, maybe at the next meeting we can talk about that. And we will want to bring to you the voices of stakeholders who are not represented here, but have some thoughts on your deliberations so that you are informed by what they are saying outside of these meetings. And ultimately, we want to deliver a consensus set of recommendations to the Health Policy Board and then to the Legislative Assembly. We would like, coming out of this, for there to be commitment across insurers and providers to meeting the cost growth target. Without that type of commitment, we won't be successful. We also, at the end of this, want to have a common framework for doing measurement about cost drivers and cost growth drivers. And then finally, and most importantly, we want to slow the underlying rate of growth of costs. So this slide, I think, number 68, really represents where we want to be at the end of this process in order to feel that we've been successful in our work. We're also anticipating that there will be a definition for how public cost hearings and our report will be distributed, and that we will have defined how collaborative actions might be initiated to address the opportunities that are identified through the analysis. This gives you some examples, waste and inefficiency, but those opportunities may exist in areas other than waste and inefficiency. And our hope is that as a result of this work, we will have developed a blueprint for how to pursue those types of collaborative efforts. So here's our timeline. Our committee is meeting, as we've discussed, through September. Your recommendations have to go to the Health Policy Board and the legislature, and they will be deliberated during the legislative session beginning January 2021. The goal would be that by July of 2021, everything will be blessed and finalized, and that in fact, during the period up to July, OHA will begin to work on the operational details of the program so that it can be implemented effective January 21. I will say again, based on our experience elsewhere, this should be more than adequate time for doing all of this. So I think this is achievable. And then beginning in January 2021, there becomes a routinized process of gathering information, reporting, holding the hearings, and it becomes a regular flow, much as exists now in Massachusetts. So all of our meetings are public. Stakeholders are welcome to provide feedback at using this email address. And again, at our next meeting, we'll talk more about the public engagement process. But just know that we're currently developing a plan on how stakeholder input can be gathered and incorporated into your deliberations. Okay, and now we're going to do a brief public meeting laws overview.
Is this on me?
I think so.
I think I think for the most part we've covered it. That folks need to, anytime that we're deliberating, it's basically a public meeting, so we need to use this forum. It's going to be recorded. The things we talked about that are really, we just need to be careful about are not replaying all, because that's something that's sort of deliberating and being a public meeting. That for the most part, I think we've covered it. Any of the materials you've got that are related to deliberations of this are public records, and anytime that a group of this group meets a quorum, basically that's a public meeting. So just be conscious of not a bunch of folks getting together and talking about what really needs to be discussed here.
Okay, and I note that I was so efficient going through all of this that we're actually 5 minutes ahead of schedule. So, so is there anything that I just covered in terms of our processes that anybody's got questions about or suggestions
I have some question. So I don't have it in front of me, but I seem to remember on the charter or something you sent out about kind of media requests going through the committee or something like that. And so if a reporter calls and asks me to talk about this, do you want it to go through the committee, or what would the...
Yeah, as Michael said, I mean, it's up to you whether you want to talk about media or not. Sort of a best practice we would say is to funnel that to OHA and to and have the OHA and the chairs be kind of the spokespeople, but that's really your guys' call in terms of whether you want to say anything publicly or not. You're not required to by any means. You're welcome to just forward Parks OA if you want to.
And by OHA, are we talking about you, or?
Yes.
Listen, okay, that's my main thing. Great. Good, because I've got your number. Any other comments about the procedures and the what and the how? This is very well laid out, so thank you very much. I appreciate it. Any comments? Okay. All right, hearing none. Do we have a public? We go to the public?
Yes.
Okay, this is a time where people can come forward and make a comment or have a question. And this is Tom Sinsick, is that right, Tom?
Correct, yeah.
Yes, hi, welcome. You are with Healthcare for All
Oregon,
in
yes.
Oregon. Come on up. Please.
Well, good to meet many of you. My name is Tom Sinsick. I'm a retired family nurse practitioner. I'm currently an RN emeritus, which means I can practice as a licensed nurse as long as I don't get paid for it. It's actually an official status. I am currently serving as the president of Healthcare for All Oregon, looking for an affordable, quality, equitable, sustainable healthcare system. As a nurse practitioner, my little background for myself, just so you understand, because I will be here kind of session after session.
Good.
I worked, my first nursing job was in University of Iowa, hospital and clinics. I worked in hematology oncology. Then I went on to my nurse practitioner training at Yale University. I worked in rural East Tennessee. I then worked for a tribe in Michigan for 3 years. I came here to work in the jail for 3 years in corrections health. And then I worked in 25 years in a school-based clinic, serving many of the kids who are covered by the number of the insurers in this room. So a variety of experiences in a variety of settings. My goal has always been to increase access to care, get rid of barriers to care, and good quality care, and no need necessarily to increase costs. And I'll just give one brief thing. One year, of all the asthma patients I took care of, many of which, again, were insured by this we kept 100% of them out of the emergency room for a 1 year, a 1 year period. And I think that in general, that's considered quality as well as cost savings. Nobody wants to go to the ER if they don't have to. So by providing access, that was really important. So I got a couple of questions. And maybe just to think about whether the people, again, to understand that they are committed to the issues of this charter, but whether people would commit themselves or to recognize across the board that healthcare is a human need. Is that a consensus that could be brought forward into this discussion, that you come to a consensus on that? And then the idea is the second one, which is healthcare a human right? Right? Maybe a little different, right? We have a lot of needs that are not yet rights. But I think these are both things to be considered. Actually, I know that the Providence Health System is currently touting that healthcare is a human right. The Kaiser system, I believe, as well is doing this. I don't know about the other missions, but Kaiser and Providence are both publicly putting that information out. So I always wonder if a person walks in to a clinic served by Providence and paid for by a Providence, well, they get mixed up between the payer and the provider a little bit. So I'm not sure if that message is the provider end that's sending out. Is there a clarification on that? Is it the provider end that says healthcare is a human right, or is it the insurance end of Providence that says that?
I would look to William Olson. Maybe both, I don't know.
It's both.
It's both, okay, thank you. So thank you for that. That helps drive the conversation going forward. And since this is a cost committee, it is hard to capture all the costs. I asked, whether the cost of the State of Reform meeting yesterday, 350 or more people showing up yesterday all day to have a discussion about this is considered a cost of the care, the cost of care. This meeting, all the time you're putting in it, the time that all of the patient navigators put in, the nurse navigators navigating insurance for systems that might be, but is the cost of the not-for-profit clinics, right, a part of those costs? Clinics, not-for-profit organizations that are using dollars to help people navigate. Well, what we hear from them is they're not navigating care, they're navigating insurance. People come to them with a housing need, medical need, all that stuff, and they're navigating. I'm not sure if that is considered, and I think that's going to be important to consider. The cost of the state to monitor the complexities of this system across the board, DCBS, the work that they do, OHA, all of that. Is that part of the cost of care that is being considered here? Are all the visits to all the alternative providers where people are paying out of their pockets because, we have a variety of systems, some cover naturopaths, massage, chiropractic, all of these various items. Are all those costs being added into the system? We don't have the Massachusetts people here. I'm wondering if they considered all of those costs. I think it's very important. Is the cost of the consequences of the thing like opioid addiction considered as a part of the cost of healthcare, other than going into the services, but the cost of homelessness, family tragedy, et cetera, are those? And I will say that as a specific thing because I remember when the pain scale was introduced, I was a pain scale refusenik, right? It was mandated by our policy, right? The county health department, well, you're going to do this in every patient. I said, no way, there's something behind this. And it was just, now it's coming to fruition about what that meant. So I just think that getting at all the costs is hard. And I will, we have concerns about tiered plans, which is an equity issue, right? The cost to who across these tiered plans. And I think that's it for now. I just want to say that human need, human right, and are you going to consider all the costs? And is it possible to do it all within the complex system that currently exists? That's what this looks like an attempt to do. And of course, Healthcare for All Oregon doubts that's going to be achievable in that pathway. But, so thank you so much.
Thank you very much for your comments. I don't know if you want to tackle any of those questions, although. What's that? We'll just take them as comments, yeah. Although, can I just, I do have a follow-up question for Michael. If somebody does go into a healthcare provider and just pays cash, and it doesn't generate a claim to an insurance plan, is that part of the total cost of care? We don't cover that because it's not in the all-payer claims data. So,
Amazing.
so your point is it's going to be a little tricky. We may not be able to get everything, but we'll do the best we can.
Well, thank you very much.
Yeah, okay. All right, are there any other comments from the public? Okay, I had one last question I wanted to ask our state economist, Mark. Do you know, it just would help me as I leave the room to understand the real challenge in front of us. We were told today that Oregonians face the 4th highest out-of-pocket burden in healthcare expense. Where do we stand in our state in relative to family income? Are we high? Are we medium? Are we low? Is it an extraordinarily high burden given where we are there?
The median family income story is a good one recently in Oregon, where in the late 70s, early 80s, when the resource industries restructured and all the mills closed, Oregon took a real big step back relative to other, the typical state. So when we're talking about median family income, if you lined all the households up in Oregon from the lowest income to the highest and pick the one right in the middle, that's what we're talking about. And so this particular business cycle has been fantastic over the last 10 years. Oregon has caught up in inflation-adjusted terms and is now a little bit higher than the nationwide average.
Okay, good to know. I was just interested. Okay, are there any other parting comments? Yes, Jordan.
I would just follow up on that. So that's median family income, but from a GDP production standpoint, where does Oregon fall in relative to other states?
GDP is at the state level is particularly difficult to measure in Oregon. Traditionally, we've always grown a lot faster than the U.S., largely because of our technology industries. But those are very hard to measure insofar as if a processor works twice as fast, is that twice as much production? And so very recently, the Bureau of Economic Analysis has changed their methodology and have revised Oregon's GDP numbers very far down from where they were before. And so that one's a question of methodology, but yes, we have been doing better than most places, largely because of our technology industry.
Sorry, not growth rate. I meant per capita GDP. Where do we fit in?
A little bit above average.
A little bit above average.
So Jack, just a question. Is it possible to take our data from 2017, 2018 and run it through the Massachusetts model just to get an idea of what pops out and, might point us in a certain direction?
That's a great question. I don't know.
We can take what we have in the all-payer claims database and try to take it apart. It's important to know that in Massachusetts, they do use the all-payer claims database, but in sort of the second phase, really around deep dives of what's driving healthcare costs. In terms of just understanding at a statewide basis, are you meeting the target or not? That actually starts with just an insurer template that they submit, and that's how they're able to get the self-insured data and some of the other data that's not in the all-payer claims database. So we can pick out from all-payer claims database, which gives us a pretty good view, but it doesn't quite get us exactly what is currently being measured in Massachusetts.
We'll dig into this in our next couple of meetings, the use of payer supply data versus using the all payer claims database.
And I guess, are we putting Medicare in this?
Yes.
Fee-for-service status, Medicare Advantage?
So I do.
Yeah.
Just looking through the committee members that we have a lot of representation from the insurance industry, from the hospital side, which would cover both more of the employed physician piece, but I'm kind of struck that we don't have the non-employed physicians at the table. So, the Oregon Clinic, Portland Clinic, some of these very large organizations that this will impact. And I was just wondering how do we address that?
Well, I couldn't speak on behalf of that as president of the Oregon Medical Association.
Yeah.
We plan to utilize our communication channels with those large non-employed physician groups so that they can be as aware as they can be with the scope of this work. So it will be through the Oregon Medical Association channels.
So you'll be their voice.
Correct.
Yeah.
We're also mapping out, and this is what Michael alluded to in terms of more stakeholder planning that we'll talk about next time. We recognize that this is a big group and yet still has some big gaps. So we're trying to map out some in-between meetings or forums where we can get input from a broader group of folks. And if there's certain voices you don't see at the table, please let us know and we'll make sure we get them in the process.
Thank you, William. Those are great comments. Thank you. Are there, yes, please, Kevin.
I have some parting comments. So one of the 5 work streams when we get to will be really exciting to do a deep dive into, and that's the quality and equity work stream. And I bring that up because we know that other developed countries in the world invest more in social programs than the United States. And theoretically, their healthcare costs are thus lower because they do that upfront investment in social programs. So we have an opportunity to be uniquely Oregon in this approach. And if we truly believe the social determinants of health impact the individual and population the most, then how do we cost account and fund for that? Because in the cost accounting we've seen thus far, it's all healthcare associated cost accounting. Second, I feel we need to also balance the inequity of physical health and the health outcomes on the individual and the population with behavioral health. And that's inclusive of alcohol and drug addiction and also trauma-informed approaches. Oregon spends one of the highest per capita for cost, but we actually fund one of the lowest in the nation for behavioral health. And do we have then a chance to start to rebalance this? And I've always believed that good and adequate behavioral health, first and foremost, begets overall health. And I've seen this in our CCO, where some of our highest cost members are severe and persistent mental illness patients that due to stigma or bias or just the fact that they cannot access the type of physical health resources, their costs are higher and their physical health outcomes are actually lower. People with severe and mental illness die at a rate that's far earlier than that of the average population in our state. So I would just challenge us when we get to the quality and equity work stream to start to keep that in mind.
Well said. Other parting comments? Yes, John.
Yeah, so I heard that long-term services and supports are in this, and I think that's not something that we've looked at in the state, and so I'm wondering if there were tricky parts to bringing that in, or if that's sort of
Yeah.
kind of exists mostly under Medicaid, or if there, I don't see it broken out here, but if there anything to think about for that group.
Well, so in Massachusetts and the other states that are measuring this, they're asking the payers, how much money are you spending in a defined long-term services? Is it nursing homes? And there's a definition behind it. And Massachusetts is not reporting it in that particular publication. I don't recall whether they've had a focus on that particular service line in the last couple of years. But when we get to the conversation about what exactly are in those numbers, then we can talk specifically about how we define those particular services. And that also goes to where we get the data from.
So can I just get clarity on that? Typically in a health plan, particularly in Medicare, in a Medicare Advantage plan, there will be claims for long-term care facilities for a small part of time. But are we also suggesting that long-term care insurance companies, that they are not in the claims data? It's really the long-term care services inside the medical spend?
Yes. So
Does that make sense?
in the 3 states that have operationalized this, they have not asked long-term care insurance companies
To dump their claims in?
You could talk about it. I mean,
We could talk about that, yeah.
It's all open.
Okay, but that has not been done in the other 3 states?
It has not.
Okay, I was curious, thank you, that is helpful. Okay, other comments? Do we have some parting instructions? Anything you want to say there?
So the assignment is to get Megan any comments on the charter. If folks have any other questions, please let me know. I'll probably be reaching out just to see, just check one-on-one, just check and see if folks have questions after you've digested this. But my other parting thought is just thank you all. We know this is a huge time commitment, and I think we've really got we've got an opportunity to build something unique for Oregon. I'll also say there's a number of other states that are looking at this, and they're looking at us because they see us as the first state on the West Coast, and also the next state that's really going through kind of a full build of this. So a little bit of pressure there on all of us to try to get this right, but thank you all for the commitment, and we look forward to working with you.
Can I end with a parting joke?
A joke? A joke from an economist?
Yes.
I love that.
So we got Craig and Mark and myself here, so I want to make sure the committee
Oh, yeah.
knows the difference between an economist and an actuary.
Don't know.
Actuary knows that they're boring.
Actuaries have more self-awareness. Good to know. All right, so our next meeting is December 12th. Everybody have a wonderful Thanksgiving in between, and thank you for your service here. We deeply appreciate it.